Okay, folks, thank you for joining us. We're looking forward to having an incredible discussion today with our luminaries, a panelist of experts around cervical cancer screening. The title of the session is Cervical Cancer Screening Guidelines and the Need for Patient-Centered Care. Towards the end of this session, if we have a few minutes, we'd like to show you a video as well about a patient champion who was a cervical cancer survivor because of the importance of laboratory testing. But before I get into that, let's introduce our panelists. The first panelist is Bob Goulart. Bob Goulart is both on our board of directors. He's an MD and ASCCP. Bob, if you would please raise your hand and say hello.
Hello, everyone. Pleasure to be here, Blair. Thank you.
Thank you. Second panelist we have is Linda Guller Blunt, also an MPH, and she's the CEO and founder of Black Women's Health Imperative. Linda, please say hello.
Hello. Good to be here with you. Thank you.
Thank you. Next is Jessica Shepard, who is an MD and an MBA and a fellow member of Obstetrics and Gynecology, ACOG, and she's the founder of Her Viewpoint. Jessica, welcome to our show.
Thank you for having me, and glad we're able to discuss this in this forum.
Thank you. I understand you just recently moved to Texas or to Dallas. Is that correct? Okay, yeah. Well, you're in a warmer climate now. Is that right? Thank you for joining us. All right, so let's get started. The session is being independently funded or as an educational grant by Hologic, and the faculty have no relevant disclosures with this one exception. Okay, next. All right, and we are going to jump right into the heart of the matter. So this is a very important panel discussion, folks. This discussion has been going on for quite some time. This isn't a new dialogue. As you're probably aware, ACOG, ASCCP, ACS, as well as all the professional organizations have been working together around harmonization to support the needs for cervical cancer prevention and looking for opportunities to bring the best empirical data and best practices to bear as it relates to the diagnosis of cervical cancer and, mostly importantly, precancerous diseases. However, because of this recent guidelines that have been released by the American Cancer Society, I think it's important to remember that the screening empowerment of patients is important. And we've been discussing this throughout the week, that patient-centered advocacy is really the critical inflection point for the conversation. We are all patient advocates, but we have to help our patients be more proactive in their health, be interventionists on their health care, and making sure that they take the right questions to their clinicians and ask for the right test at the right time, and sometimes for the right price. So I think the good point of the conversation here is that we have an opportunity to remember that these patient advocates serve a a crucial role as a conduit between what we do as a practitioner, what clinicians do as interventionists, and what the patient must do to protect herself. So today, these panel of experts are going to discuss cervical cancer screening and precancer detection within the United States, the environment of the United States. Of course, each country has a little bit different of a nuance in how they approach this particular disease, but this panel is going to address recently published guidelines from the American Cancer Society, the American Society for Colposcopy and Cervical Colposcopy, or Cervical Pathology, ASCCP, and the United States Preventative Task Forces Service, USPSTF. And I think the good news is this came out in about a month ago, and we've had an opportunity to digest it, think about it, work on it, look at what the implications may be, and that's why this panel is willing to share their thoughts today as to where we think this might take us or what we should do. So our panel explores this impact of these guidelines, and it explores how these guidelines will affect patient care, and not only the clinician side, but of course on the laboratory detection side. So the more recent guidelines that we've been referencing here from the American Cancer Society were published in CA, now that's their journal, as a cancer journal for clinicians, and it was published on July the 30th. And the new guidelines recommend, and this is the critical conversation, the new guidelines recommend that individuals with a cervix institute cervical cancer screening at the age of 25, and they undergo primary HPV testing every 5 years through the age of 65, and that primary HPV testing be the preferred screening method. It goes on to say that co-testing, which is HPV testing in combination with cytology, i.e. the pap test, every 5 years, or cytology alone every 3 years, are acceptable options if primary HPV testing is not available. So I'll read it to you one more time so we can all digest this, because this is really the crux of the conversation. This is a shift in the paradigm in terms of patient care and the wellness visit, but more importantly, the clinician's intervention with the patient, because he or she is the individual that will make decisions on that patient's health. The new guidelines recommend that individuals with a cervix institute cervical cancer screening at the age of 25 and undergo primary HPV testing every 5 years through the age of 65 as the preferred screening method. And co-testing, HPV testing in combination with cytology, every 5 years, or cytology alone every 3 years, are acceptable options if primary HPV testing is not available. So let's start right away with you, Dr. Goulart, who is a leader in the cytopathology community. He's a pathologist, also sits on our board of directors, and has been extremely involved as an empirical scientist over the course of his career around the implications of these guidelines. And this is just the latest conversation that we're having. But Bob, you've been a leader for many years. Can you describe the evolution of cervical cancer screening guidelines in your career, just the evolution, and give us some of the highlights as well?
Yeah, so thank you, Barrett. Really, it's a pleasure to be here. These guideline reviews happen every 5 to 7 years, and often they take up to 10 years to really become sort of in place in the community. So our last review was in 2012. So now it's been a pretty active time for the past 2-3 years in the pap smear world, quite active. So just to recap a bit, so in 2017, the United States Preventative Services Task Force came out with their screening guidelines. And as you know, we responded through our cytopathology consortium to those guidelines. And the draft guidelines actually had fully removed co-testing, pap test plus cytology, from their category A recommendations for screening. So that was sort of a shock and awe moment. We all stepped back and said, wait a minute, it's not there at all. And we had quite a bit of push back, if you will, to that. And through our consortium had many issues, especially in 2017, which, as we'll get into, primary HPV hasn't really caught on in this country for a variety of reasons, even though we are in that transition period. So we did push back, and their final draft, final proposed guidelines did brought back in co-testing. But clearly that was sort of the line in the sand a little bit, that primary HPV and that transition to primary HPV was really on the forefront of many scientists in this country. Then we move forward to 2019, where the ASCCP looked to management guidelines for women with abnormal cervical cancer screening tests. And that was really a federated 20 society. We actually had 10 pathologists, 2 in leadership roles, 8 pathologist representatives, 25% of the voting body, to look at the management guidelines and to make sure that those were in league, harmonized, as you mentioned, with the SGO, the Society for Gynecologic Oncology. And those came out earlier this year. And then the large one, the ACS guidelines that just came out for cervical screening, were largely based on the micromodeling that the United States Preventative Services Task Force had put forth in 2017. And you've gone over them in nice detail, just what they promulgated. I would take it even a step further, that they do mention that as the transition happens nationally to primary HPV screening, that cytology and co-testing options, cytology plus HPV, should be dropped as screening options for women. So although they are acceptable today, there's a strong impetus that we do transition as it becomes more available to really primary HPV testing, which again, the pathology community does have some issues with that we'll discuss a bit later, just like we did in 2017 with the United States Preventative Service Task Force recommendations.
We're going to cue that up for a little later in the conversation, Bob, what the implications might be. But before we do, I want you to tell me, has this been a coordinated effort with ASCCP and other organizations? If so, which ones? And is there a consortium that's working synergistically, or at least in a homogenized way, so that we're not doing one-off conversations with ACS?
So the cytopathology community is a pretty close-knit community, the pathology community as a whole. So in 2001, two inter-society consortia fused to form what is now in its roughly 20th year, what we call the CETC, the Cytopathology Education and Technology Consortium. And that has 6 society representatives: the ASCP, the American Society of Cytopathology, the American Society of Cytotechnology, CAP, the College of American Pathologists, the Papua Society of Cytopathology, and the International Academy of Cytology. So really all the 6 major pathology organizations focused on diagnostic excellence in cytopathology, cervical cancer screening, have formed this consortium. We all have representatives that are sponsored by each society. And it's really a wonderful thing to have, because when these guidelines come out, and the proposed guidelines are only open for public comment for a number of weeks, we have to move quickly. And it's worked very well to get a federated group response. So we speak as one voice. So just like the ASCP stands stronger together, certainly as one pathology voice, we've put these issues forth as a federation with all society presidents signing off on them. So the CETC, for the people out there in the audience, ASCP members or not, your cytopathology community has really been active in this process over the past number of years. And
just in the spirit of full disclosure, because this organization is a member of that consortium, we are very conscious of the fact there could be implicit bias about our perspective as it relates to what we believe are implications. So this is a very empirically driven, data-driven process for which these societies respond, without trying to look as if they're protecting, their own practice. So again, I think it's an important conversation to have, because, not always easy conversations to have, but it's important that we do throw that out there as a primer for the dialogue. Let's go to Dr. Shepard. And Jessica, it's really great to have you on the panel today. You've practiced as an OBGYN in both Chicago and now in Dallas. Welcome to the warmer part of the world. I'm really interested in, I know you're the founder of Her Viewpoint, and we've seen your patient empowering messages. Let's see, we've seen them on the Today Show. I've seen them on Steve Harvey, Dr. Oz, others. And this is phenomenal, the way you are empowering patients and being proactive in their voice. And thank you for doing that, because that's part of the messaging. It doesn't matter if it's COVID or cervical cancer, patients have to step up. Now in 2020, and with these new guidelines we've been discussing, how will gynecology respond? And how, more importantly, will women be empowered to ensure that they never have to worry about this disease?
Those are great questions, and that's why I'm so thankful that these types of conversations can happen, because we can really get to the crux of the pathology of the disease, but also clinically how that now disseminates into a community, and how women take that message, what they can extrapolate, and how they use that going forward into their well women care from their perspective as they advocate for themselves. So as a practicing gynecologist, one of the things that we do see is when there are a lot of changes in guidelines, and not to say that guidelines should not be changed, clinically, we have to make adjustments to that. and find out how do we now, one, change that muscle memory, I guess, if you want to call that, between how we counsel patients, how we treat them adequately, but also making sure that the message that we send to patients is understood in order for them to act in their best interest. So seeing these guidelines, I think there are multiple levels at which we know that HPV is the leading cause of cervical cancer, and that is a very important part of how we deliver messages, how we counsel patients, screen them, and then also how we decrease those risk factors for cervical cancer, because cervical cancer actually is one of those things that we can actually prevent, screen for, and cure in some patients who we have early detection. Now, when guidelines have moved and shifted in age, when we think of us starting at the age of 21 with the previous guidelines that were from 2012, and using that in a code testing fashion, and now going to HPV only for 25, I've had obviously side conversations with other OBGYNs and having their opinion on what that really means to their practice and their collective patients. I've had actually multiple different analysis from their clinical perspective on what that means for them. And I've seen anything from, yes, this is something that we need to move towards, as far as making HPV maybe what we focus on. But from most gynecologists, and including myself, sometimes we have to encounter, and this is taking it from the patient perspective and that relationship that we build with patients. And also when we think of healthcare disparities, we want to make sure that this is something that is going to be for every patient. And with every patient, when you think that way as a clinician, which is how all of us should be thinking, is we have to think about patients who maybe have lack of resources, lack of access, lack of care, and sometimes the ability for them to access, whether it's where they get their care, how they get their care, the length that they have to go through in order to get to a visit, if they're going to have access to what we propose as the new guideline and when that should start. And the other thing that kind of rings out when I think of these guidelines is that relationship. One of the things that is imperative is why we still see cervical cancer is because the relationship of what a woman thinks is important to go to her doctor in the first place and why she goes, and even understanding the simplicity of what a pap smear is. And there are many patients who still don't even understand what it is, what we're screening for, and how we can decrease that. So I do feel as a clinician and a patient advocate, starting those relationships a little bit earlier helps to create that momentum where patients can understand the importance of why they get testing, how often they need to get testing, and also the resources and how we can help improve their ability to have those resources available to them. So I think it's so multifaceted when we think of these approaches, but from a clinician standpoint, I always try and take a step back and think, yes, I'm a scientist, and yes, I love research, but I also want to make sure that this is inclusive with my patients from whatever socioeconomic background, racial background, whatever that means, that I am going to create this environment for them as well.
That is a wonderful answer, but an incredible preamble for the next conversation, actually. And thank you for being clairvoyant, because that is exactly what I wanted to start talking about. As you were going through the dialogue about healthcare disparities, okay, and this came up yesterday in our opening with Rita Wilson as well, about healthcare disparities. The Black and brown population have been clearly disproportionately affected by COVID-19. And that is an impending apocalypse if we don't figure out a solution to this. So let's take that what we know about what's happening in the current environment of COVID. Now let's take this over to Linda. And Linda, you are in charge of, and you're the CEO of Black Women's Health Imperative, and you're an epidemiologist as well, and you're a patient advocate, as well as Jessica. What do you think? What are your thoughts, Linda, in terms of how disparities could be disproportionately affected by a guideline? Whereas Dr. Shepard said many patients don't even know what they're being tested for and how they're being tested.
I know. Thank you. And that is so true. Dr. Shepard is right. I mean, we can't make it the patient's responsibility to keep up with these guidelines and to know what's best for, for the patients. The patients rely on the Dr. Shepherds of the world to help them through that process. But also the Dr. Shepherds of the world are aware of the disparities that exist in access, in information, in ability to pay. And, with the Black Women's Health Imperative, we've spent 38 years helping women advocate for themselves, not saying you got to be an expert, but here are some important questions to ask your provider, and here are things that you need to know to make sure you get the best care possible. And we really like to depend on data to inform this decision-making process and to inform and drive our programs. And so when you look at something like cervical cancer, which Dr. Shepard said is entirely preventable, Black women die from cervical cancer at more than 2 times the rate of white women. So we've got this huge disparity. This is, Latinas, again, increased mortality. Black women, we know epidemiologically, develop cervical cancer younger, and they tend to get a more aggressive form. So one has to ask oneself, there's delay in screening because of access, insurance, transport, all the things that Dr. Shepard talked about, location, types of jobs, can you get off time to even go to the doctor? So our diagnoses tend to be later stage. So knowing all of that, why would we stop looking for cervical cancer? Why would we raise the age at which we start looking for something that we already know a group gets younger? And it's not clear how the data informed this decision to change the guidelines. And I just want to note that ACS, in its description of guidelines, admitted that Black women have significantly higher rates of cervical cancer and mortality, and that there are challenges with the studies relative to women of color. Yet, by changing these guidelines, we could in fact widen the disparity gap between Black women, Latinas, and white women. And so even though they've admitted this, they've gone ahead and essentially said, well, we know more study, more research is needed, but we're not going to do that. We don't have time. We're going to go ahead and issue these screening recommendations. And so what they want us to believe is by removing co-testing, removing PAP, by raising the age, somehow we're going to lower incidence and mortality. And I'll just sort of draw our attention to another train of thought that's kind of gone around about not testing being the way to not find more incidences of disease. I won't name who said that, but some other people have that same thought, and it doesn't work. The results are, and the consequences are disastrous. It's not logical. So what we've created, in a sense, is more confusion. Patients don't know. And we could even create confusion among the provider community. Providers want to do the best. They want to provide the best care for their patients, but then they're looking at differences in guidelines and also looking at who was in the studies and who was not in the studies, and having to sort of make a decision about what's best for their patients with perhaps incomplete information. And then we add on top of all of that COVID-19, where we know women are afraid to go see a doctor anyway. They're afraid to go into the office. They don't know. And so that's yet another reason to stay home. And we honestly do not need to give women another reason not to get screened.
Yeah, and listen to you talk about this, I agree. I think in a way, sometimes scientists are the enemies of their own science, because they create such a perfect storm of being, perfect storm of being as specific, as sensitive as we can. But I mean, this is a public health message, isn't it, Linda? I mean, this is a message that we've known about since the 1940s. There's no reason for anybody to die of this disease. I don't care what color you are. I don't care where you live. I don't care what your socioeconomic background is. There's no reason for it. I work in countries where it's still the #1 killer of women, okay? And it used to be the #1 killer of women in the United States of America until the PAP test. It's still the most successful cancer screening test of all time. But now we're trying to take, it to the nth of perfection, right? And if I ask you, Linda or Bob or you, Dr. Shepard, if I ask you, have you ever heard of the flu shot? I bet you know the answer to that. But if I asked you, have you had your Pap test this year? A lot of folks may not know the answer to that question or why they needed the answer. One is a flu shot. Sorry to say, no, not as virulent as dying of cervical cancer. Maybe one of the worst diseases to die from, period. And wiped out more women before the Pap test ever existed. So we've got to be careful about taking it to the nines, as we say. How far past the nines do you want to go? And I think the public health message here for us is that we do want to drive data decisions or data empirically driven decisions, but don't we also want to make sure that you capture the people and save their lives with whatever it is. So I'm going to move over to a minute here and not to go in a soapbox, but I work in countries where they have 4 or 5 different types of platforms for testing for cervical cancer. And it may just be one in Tanzania and maybe another, you know, over in Zimbabwe. And they ask me which is the best. My answer is always the same. Any test is better than no test, as long as patients get access. Let's start there and get rid of 90% of the disease, and then let's try to get to the nines. My next question will be to you, Dr. Goulart, and I'd like to ask you, okay, so you were tasked by our organization, by even our board of directors, to look at the evidence of the United States Preventative Services Task Force guidelines. And you were asked to provide comments in the past on both the ASCCP guidelines as well as the American Cancer Society guidelines that we're talking about today. Can you talk about the new guidelines and what you consider to be issues regarding the supportive data for primary HPV testing and screening and specific considerations thereof for cervical cancer prevention in our country?
Yeah, I'll just quickly touch on the ASCCP management guidelines because there's some quick paradigm shifts there that we're moving to more personalized care. It's not just a test drives treatment, but it's the personal risk that the patient has that drives treatment. So we take patient history into account. You're not just following an algorithm of one test leads to one management intervention, and also that they're risk-based with cutoffs for management. So equal risk equals equal management. And they're driven by HPV-based treatment. So HPV is a great test. The question I think we'll get to in a moment is whether it should be again coupled, whether it's a stronger test coupled with cytology. So there really are some, I think, excellent paradigm shifts for the ASCCP management guidelines. Now let's move to the ACS screening guidelines. So there are some, you know, as laboratorians, it's our job to get into the weeds a little bit and into the details and to make sure it's the right test for the right patient at the right time. So of the 5 HPV platforms that are commercially available and FDA approved in this country, only 2 currently are FDA approved for a primary HPV indication. So I'm sure patients probably think, sort of like COVID tests, well, an HPV test is an HPV test is an HPV test, but they're not. And there are different indications that the test platform has to be, have FDA approval for those certain indications. So one of the difficulty issues, even when the first primary HPV platform was FDA approved in 2014, there really hasn't been an uptick of ordering for primary HPV testing. I mean, I run a pretty active lab, and I have to say in 6 years, I've not had one, and it's a fair minority in the country. So most of the platforms in the country are not approved for that primary HPV indication. So we have to make sure when the clinicians who send us our PAPs know what testing platform we have and that it may not be approved for the indication that we want. And it's behooved to us to make sure we only run tests on a platform that it's FDA approved for. The other issue is the HPV test is an excellent test. Let's get past that. It's got super high sensitivity. Its negative predictive value is excellent, but it's not perfect like any test. And there is a subset of precancers and carcinomas that's not terribly insignificant, maybe in the 10% range, that will HPV test negative by the commercially available platforms that we have. And that subset of patients, especially with 5-year screening intervals, could sort of pass through screening and just be HPV negative with a case that a good cytotechnologist and cytopathologist could readily diagnose based upon a morphologic pap smear if they were co-tested. The other issue is, and this is getting in the weeds a bit, but the internal controls, if you're going to remove cytology on the same vial is just the best morphologic control you can get, because you're looking at the cellular sample in the specimen that you're HPV testing. And most of the platforms have an internal control to make sure a specimen sample was taken. Is there patient DNA or RNA in the vial? But they don't have a morphologic control for the real target, which are squamous cells. You know, how many squamous cells are present? Are they, you know, well preserved, on and on? So you could have a pap that's loaded with inflammation that doesn't have enough squamous cellularity that could potentially pass through an HPV primary only test to be negative. And it doesn't have the right target for the test. So all of those put together, we really think that there are some strengths with adding cytology to an HPV test. And certainly we need time as a country to migrate towards testing platforms that can handle primary HPV, that clinicians understand that there are different platforms and indications. And that was the issue in 2017, and I think it's the same issue today. We're just not ready on a practical standpoint for this transition to primary HPV.
So, you know, without going into the details of the modeling, because I don't want to get too far down the weeds, because there's questions around the patterns of practice in the United States, as Linda indicated earlier, and our ability to make sure patients get access, and whether that was balanced in the guidelines or not. But what I'd like to ask is sort of more a pragmatic question that you pointed out earlier, and this is for Dr. Shepard. And that is, you said, and let me see if I can get this right. You said in your practice, very few or one or less of these assays have been readily, reliably used, and paraphrasing now, by your clinicians, okay, the Dr. Shepards of the world. And they're not looking at primary HPV testing. Dr. Shepard, is it because it's a wellness visit for patients? And it's because we have to capture the population, as Linda said earlier, to make sure, you know, we don't miss an opportunity to do pelvic screening, breast exam, anything that's necessary to do the well-being on that patient care? Or is it that the uptake on primary HPV testing is simply not necessarily even on your radar screen, and maybe doesn't propose a threat as might be thought by these guidelines?
Yeah, no, that's a great way to kind of figure out how this would, or why clinically this may not be, or be something that clinicians would want to do. So when I said earlier about the relationship, I think that's one of the most invaluable things that when we think of physician-patient relationship, that, like you were saying earlier, as scientists, we want to like take it to the nth degree. Sometimes taking it to the nth degree removes that humanistic part of what we want patients to know about, and how we're going to get that message to them. Many times, if you think through the past, there was a point maybe 3 years ago, 5 years ago, where they were trying to eliminate even the pelvic exam during a well-woman visit. And that again was trying to take away some part away from the well-woman visit. And I think that what we don't realize is in a well-woman visit, you can go over birth control, contraception planning, family planning, breast exams, start checking for metabolic disease such as diabetes, hypertension. Even those things can be covered in a well-woman visit. And so when we try to nitpick kind of like the bread and butter of that visit, which is the pap smear, and if you ask anyone, OBGYN, when you go there, either you're pregnant or you're going for a pap, right? And so when we remove kind of like those pivotal things that people relate to what a well-woman visit is, then that's when you start to lose a lot of people, or they figure maybe it's not that important. Maybe I don't need to go. Again, because there's an educational foundation that needs to be established, which we already, how many years are we out from developing the PAP? And still yet we have a good portion of our population who, if you were to quiz them and say from this multiple choice answer here, this question, what is the PAP for? I'm not quite certain that everyone would get that right multiple choice answer. And so again, there's still a lot of like different answers and concepts of what the pap smear is, but everyone knows probably around 21, because we've made it that for so long, that's when they should go. And so changing that, and I've had, when we were talking earlier and we opened up this session, we said what clinicians thought, and I was just giving opinions on kind of what I've heard in a very small collective group, so it's not very, it's not all across the US, but there have been patients who the first thing they brought up when we were discussing moving the age to just HPV starting at 25, all they could remember were those few patients that they had who had cervical cancer, so not precancer cells, but had cervical cancer who were younger than 25. And so that kind of resonated with me, is that they were still able to, and again, it doesn't have to be a significant amount of these women, but they remembered those people in their patient population who were diagnosed with cervical cancer and maybe possibly passed from it, who were under the age of 25. So that's, from a physician standpoint, that's where the heart of this is are we doing harm to any of our patients? Again, not necessarily doesn't have to be the significant part of our patient population, but that's the first thing that they were talking about. And that's what's most important, again, is drawing into this, the patient experience, and also who we're impacting and who is going to be missed.
It's interesting to hear you to say that and keep referring to, the wellness visit and the women have a portal. Men have no portal. There is no such thing as a wellness visit for men. They don't go to into his or her doctor for a conversation because the disease they have starts later in life, right? Prostate cancer or whatever. But the irony is that the wellness visit sets up the entire strategy, whether you're screening for metabolic diseases, like you said, or sickle cell or whatever it may be. Okay. And I'm also fascinated by the conversation on the age. And Bob, I'd like your thoughts about this too. But it's hard for me to think outside of a bubble because we work across the world in this organization. And this is a disease that, if it's high risk, has the potential to become malignant 8 to 10 years. Okay, well, individuals starting having sexual intercourse at the age of 15 all over the world. And that's not, 25 couldn't be a magic number because that's a person that would have invasive carcinoma. And now we're talking about a totally different strategy. We're talking about a situation where she can't have children. And we're talking about situations that could potentially threaten her life and that of her family, okay, and the caregivers, and being a breadwinner within society. So this is a very important conversation, I think, this age. This inflection point sometimes is easy to talk about from an epidemiological standpoint, because that desensitizes the humanistic, what is this person's life versus this person's life, right? And no life is acceptable to be lost, right? We need to cast a net, period. Linda, I'm interested in your thoughts around what messages, do you have messages, preordained or otherwise, what messages about cervical cancer prevention can we share to deliver to at-risk populations in our country? And for that matter, maybe we can take this and share across the world as well.
Yeah, I mean, there's one critical message that everyone has said, which is you don't have to get cervical cancer. You don't have to die from cervical cancer. I mean, that's the message. It's not necessary. We know how to prevent this. In listening to the conversation, what the thought that occurred to me was, somehow we're running the risk of letting the perfect become the enemy of the good. And we don't want to do that when lives are at stake. I mean, you've got the models that Dr. Gollard mentioned. The USPSTF and ACS came to different sets of recommendations based on the same model. We've got a couple of studies in there that look at HPV only testing may miss as many as 20% of cancers. And the thing that I want to point out is that's really important around messaging is for all the other guidelines, recommendations, there's this discussion about shared decision-making. Not so for cervical cancer screening. It's like, where is that discussion between the patient and the provider? Where is that shared decision-making? And so, people with the cervix are somehow not invited to participate in their own care. So the message is have the well woman visits, ask just go in and ask. We tell women all the time, ask your doctor, do I have cervical cancer? Just in case somehow the provider's forgotten to screen. Oh, right, we need to do that. Ask what you should do, and ask what is happening. Because most, I know Dr. Shepard knows this, people will go, they'll get exams, they don't really understand what they're being checked for. So just ask, what is going on? We want to make sure that women have all the information they need to make the best decision they can about their health, and then act on that decision. And if they're not invited to participate, if they don't get the message that this is one of those cancers that can be prevented, there are not a lot of them, this is one, then do everything you can do to prevent it. And we know how to do that, so it's not magic.
Right, and I think when you bring the point up about not everybody gets the opportunity to have Dr. Shepard as their clinician. Let's put it that way. Let's start there, okay? So, but there are all kinds of systems. There's healthcare systems. There's PAs. There's community healthcare systems. All kinds of family medical practices. And if you think they understand the the evidence-based data behind these guidelines, think again, okay? Because they're simply taking what they're reading and assuming that they have to just extrapolate it. They're not thinking about the repercussions, because they may not see that patient again for 5 years. They don't have the opportunity to see Dr. Shepard. So, interventional clinical intervention comes in all kinds of forms, and there are very few Dr. Shepards in most of the parts of the world that we work. Okay, but they have to get access to a clinician extender at some point, and don't assume those clinician extenders know everything about these guidelines, right? So let me take something that Linda just said that was interesting to me and ask you, Bob. She's talking about getting the messaging out, right? So let me ask you, do you believe, as a pathologist, laboratory practitioner, you're not a clinician, okay? You may occasionally see patients for needles or other things, but for the most part, this is not the forefront of your clinical intervention. So do you think, based on what Linda just said, that laboratories need to be more proactive in getting the messaging out about preventing cervical cancer, especially in vulnerable populations? Do you think we have a fiduciary responsibility to do so? And if we do, I'm going to assume that you might think that, but if we do, how are we going to do that? I mean, what should we do in order to get that message pervasive?
Well, we're people, we're physicians, we're laboratorians, we're technologists. We took an oath. So, many of the points that have been made are right on the money, that the pap smear is a cheap, thickly smeared 2-slide that we all sort of struggled with for many years, reduced cervical cancer mortality 75% in this country. And it's relatively, for the past 20, 30 years, and it's incrementally decreased, but not in huge waves. We've kind of hit the wall. And we're just talking about primary HPV testing, but in industry, and God bless them, but they're moving forward with biomarker assays, extended genotype persistence. There are all these new things coming that could potentially make, take the pap test to the nines, as you said, Blair. And I struggle with that, because we're making it a better and better test, but it's also getting more and more complex, more expensive. And we don't see in our pathology practices patients who are screened who die of cervical cancer, or who come in with, a locally advanced disease. I'm sure our clinical colleagues don't either. The patients don't die of cervical cancer because of a failure of any of the platforms. They die of cervical cancer because they're not being screened, either unscreened or poorly screened. So I think we have to step back as a society. It's really a tragedy that as a society, with the amount of resources we have, we don't have a national screening program. It is tremendously opportunistic. And as you mentioned, that's sometimes a difficulty in looking at overseas studies in Europe, Australia, et cetera, where they have callback letters, national registries, et cetera. And it makes it scary that we're not reaching the people that we need to. We're making a test more and more expensive, more and more fancy, that is pretty damn good already. And that this disparity may increase. And the people who are dying of cervical cancer currently are just not in the program. They're not being screened, period. And how do we get out there? So I think it's medicine in general. And I think certainly the ASCCP and laboratorians are right there to say, we believe this too. I'd rather have everyone screened with a simple test that's moderately good than a subpopulation screened with the perfect test.
Dr. Shepard?
Yeah, I think Dr. Gillard, those are wonderful points that you're bringing up, because that's what you would think we were trying to find, is like what it is testing wise from a histology, pathologic or pathology side, and then merging that with the integration of physician-patient relationship. You said when people die, it's because they're not getting screened, because it is, again, preventable and curable. So there is that time frame in which something's being missed for that patient, and then they progress to that side of cancer where it's obviously too hard to treat or cure. So, as we go through these discussions, especially in a panel as interesting as this, is what would you think, and I'm posing the question to you, would be that seeing this change in the guidelines and knowing where we've come from, what do you think that sweet spot is?
Is that to me, or? Yeah, so, it's a challenging one, because certainly, we have wonderful industry partners who are coming up with phenomenal ways potentially that will open the door for self-collection, which I think is, been adopted in many countries. And I'd rather, again, go that route than limit 30% of women, especially those women at high risk, as we've talked about, socioeconomically, women of color. So it's a difficult balance. I think sometimes our field gets a little bit caught up in the technology and the science and how cool and wonderful this is. And then we should drive downtown in all of our cities and see inner city women and remind ourselves that, that's the population at highest risk that we're not touching at all. So it is a difficult balance. I do hope that breakthroughs will be coming that will allow self-collection, just like we're looking at that for COVID, that you could move in that direction for cervical screening. We could have cervical screening, forums and going into inner cities. But we have to keep in mind that we're polishing a pretty damn good test already with a lot of money and time spent, and none of that is touching women who are being non-screened.
So, Dr. Shepard, Dr. Gillard said that, he took an oath, right? So you took the Hippocratic Oath, do no harm. And so here comes a patient into your office. You haven't seen her before. She's a new patient. Just call her 24. Just call her 24 years of age. You do your nurses do their history. You do a history. You find out there's been a significant high risk pass for this patient. Are you going to tell that patient not to get, or to wait until next year to get an HPV test?
Absolutely not. And
Well,
that's
my question. So
yeah, and what comes with that is, because again, it doesn't even have to be a lot, but you remember those patients that were missed somehow in that, even 18, if they were that young, to 25, that could have been screened. But also that's an opportunity to educate, right? So even if I was like, I'm going to follow the guidelines and wait till next year, at that point, it still is my responsibility in that do no harm to make sure that that patient has a full understanding of what cervical cancer is, what screening, again, depending on which one we're talking about here, and why it's so imperative for them to advocate for their health in that particular manner, which, Linda was saying earlier, walk in and say, do I have cervical cancer? Because I get that question too. And I'm like, well, wait, no, you don't have cancer. Who told you that? But then that is a learning point. That's where we start the conversation. And that, again, goes back to the relationship. So that now when my patients return to me, whether it's in 1 year through they come every 3 or 5, which I still advocate to come annually, even though they may not get their PAP every year, is to continue that conversation, that relationship, so that they're well informed if there's something that changes, whether it's symptomatically from their end that we're talking about that, or like now if we have a guideline recommendation change, what that would mean and how that would change the conversation. And so for me, yes, I would have her screen her with HPV co-test.
Linda?
Yeah. And I just want to say, to your question, my concern is that Dr. Shepard wouldn't see that patient at 24, that she might not see that patient until she was 26 or 27. And a lesion that could have been caught when it was precancerous at 24 won't be. And now she's having a very different conversation with her patient.
Well, that is very true. And in this country where people are putting off families later and later as well, they may not be coming in for that visit because they're not thinking about, they don't know about the guideline. There's no magic number 25 that's ringing through their head. Oh, I just turned 25 this year. It's time to go get my wellness visit. It certainly is not going to pop out. But of all the three of you that are talking, or the four of you that are talking, three of you are talking, I'd like to ask this question, or maybe I should pose this a little differently. There's only really one person at this table today who squarely has the empowerment to make that decision. That's you, Dr. Shepard. Because really, you're the patient portal, okay? And you're the individual that will decide what's best. You have to serve as a patient advocate, a clinician, and sometimes as a caregiver, right? Because you never know. Maybe these people need access, whoever they might be. You've never seen some folks before. But my biggest question is, if you read the guidelines, that squarely the decision is right in your court. It's up to you to decide whether or not the guidelines are of utility to your practice and is important to you. And as you saw the language and the guidelines as it was written, there's sort of an out, isn't there? The out is whatever you think. And the out is also, do you have access to these testing? And just like Linda said, if they don't get the opportunity to see an expert like you, okay, that's the conversation that has to be had. We have to make sure the patients get some kind of test. But it looks to me like you're squarely in the decision whether or not you want to ask for an HPV test or not as the primary vehicle for a 5-year interval checkup with a patient. And my question to you is, what would you do in any of those scenarios that Linda or I just gave you?
And I think I would still go back to knowing my patients, knowing what my main job and responsibility is to make sure that I am their advocate. And, just like Linda was saying, that again, because of that education piece that may not come with why we get a PAP and co-testing, and also what that really means. Many patients think it's literally just to check down there to check for STDs outside of HPV. And so those are opportunities missed. That's how I feel about that. Those are opportunities missed. But even the information, which I'm so glad that this forum is happening, that I've learned when it comes to, losing that morphologic strength in a test when you have co-testing, not being able to have the DNA from that particular patient that has the HPV, and then the FDA approved tests. There's so many, now there's all these other, kind of filtering moments where, you have kind of like that leaky faucet and something's just falling right through. And that actually increases my responsibility to be able to try and catch all these various areas where I may not be the person that's responsible for which HPV test that we have access to. And also now from the pathology side, like what pathologists are challenged with when they have one without the other. And those are questions that I think if we could make that more simple and make it more streamlined for patients and make it easier for them to understand and to get that into their muscle memory of why they go to their well woman, then I think that we'll see more impact there. Instead of getting so granular and nuclear with the HPV test, is really focusing on the broad scheme of education, making sure patients have something that's consistent and reliable. And then from a clinician standpoint, also making sure that we're not having all these different changes that we can't even keep up with the last guideline recommendation change that we had in 2017.
Well, there you have it. I'm going to have to close this, and we're going to do two things. One, I'm going to close with a quote from Linda Blunt, who's just said what I, in my opinion, I think was maybe the most important prophetic conversation of the morning. And that was, don't let perfection be the enemy of good here, okay? We just need to get a test. And we need to make sure we're caregivers for our clinicians, for our patients, we're custodians for the right science. And Dr. Gouliard and I can spend all day long defining the nines and taking it to the nines. But I travel in 90 countries in this world, and I see more PCR machines covered up because they can't get reagents, okay? They can't get HPV reagents. And they want to know, what do we do? So a test is what's necessary. Co-testing, PAP testing, HPV testing collaboratively, but you are the entry portal as a clinician, and really the ball is in your court. That's the way I read the guidelines. And thank you very much. It's a phenomenal, phenomenal conversation. I'm going to ask Martin to quickly show us a patient champion video, if we just have a couple minutes, and Martin, take it away.
I can still viscerally feel what it felt like to get that call. I can actually hear my doctor's voice in my head, and I can feel how my body went cold. I'm Danielle Sepulveris, and when I was 24 years old, I was diagnosed with HPV. I was considered high risk with precancerous cells. My first irregular Pap test came about during my regular annual visit, which I didn't think anything of because it was just my regular annual visit and I had no symptoms or any sort of issues that I was going in for. And after I went in a couple of days later, my doctor called and said that my test had come back irregular and that I needed me to come back in for another one. And then I went to get a biopsy, and that confirmed my diagnosis. They did think that I was high risk at a certain point, which was why they moved ahead with cryosurgery twice to try to remove the cells, and then eventually a LEAP, which removed part of my cervix, which officially is what got rid of the precancerous cells. Since then, now I've had almost 14 years now of all clear Pap tests when I go to the doctor and clear HPV tests. It's so bizarre that you can feel perfectly fine and something could be going on inside your body without you even knowing, and that's actually really scary when you think about it. Laboratory tests were incredibly important and essential to my journey because without them, I wouldn't have known anything that was going on. Knowing in advance or knowing before something is an issue is how lives get saved. And I think all the time about how differently it could have gone for me. I feel the lab saved my life.
And let me leave you with this thought. She was 24 years old. With that, thank you very much to our panelists. It was an incredible opportunity to get to work with you. We're looking forward to hearing more about you, seeing you all over the television as you are, and mostly serving as a critical role for NEAF as patient advocates. And please, please, don't stop the fight. This is an important disease that we need to eliminate. And thank you, Linda, for the prophetic words. Have a great day, folks. Thanks for joining us. Bye-bye.